Welcome to the Da Vinci Trebuchet presentation, Implementation Guide Overview. This presentation provides a brief overview of the Da Vinci implementation guides, known as IGs. The discussion provides insight into connections between IGs and how they address regulatory requirements. The information is intended to help the user understand how the guides work together and to support an approach for implementation. Please note this presentation provides a brief overview of the IGs. For detailed information about each IG, please view their specific page found on the Da Vinci HL7 Confluence site. This information is presented by Scott Rossignol of eHealth Exchange. Scott is a co-lead of the Da Vinci Project Trebuchet. This information was developed by Scott in collaboration with members of the Project Trebuchet core team and with input from the Da Vinci implementation guide leads. Thank you, Scott, for sharing your expertise in this presentation. This presentation and all Da Vinci presentations and meetings are offered under the HL7 antitrust policy to ensure appropriate collaboration and information sharing.
All right, so welcome to the presentation here. We're going to provide a quick overview of the Da Vinci implementation guides and try and connect the dots around these guides to help you understand how they work together and how an organization might approach Da Vinci guide implementation in general. So I think we are recording this and we will plan to put this out there in the internet later. Please do chime in if you have questions, though. If we need to clean up a recording later, we can do that or re-record this presentation. So don't be too worried about that. All right, so a quick agenda. We're going to look at those Da Vinci implementation guides in a little bit of detail. Stay at the high level, a summary of the guides and what they do. We're going to talk about regulatory topics and how those regulatory topics influence those guides, and talk a little bit about next steps and how you might approach this. As a quick disclaimer, this is an overview. These are not going to be the most detailed presentation of each implementation guide. We're making trade-offs between some accuracy for brevity here, so please bear with me. If you have questions, we are happy to get you in front of the right experts if we're not able to answer those questions immediately. Okay, jumping into the guide overview here. So the first guide I want to talk about is the Health Record Exchange, or HREX guide. This is first on the list because it is a foundational guide. It is not one that you adopt or implement alone. You will always implement the HREX guide in tandem with other guides like the CRD for prior auth or CDEX. What's important about this guide is that it enables certain functionalities that are shared across other Da Vinci guides. For example, task-based queries, the ability to submit a task to a responder and have that task worked to obtain data back, or dynamic client registration, which is an authentication concept that's used across guides. There's additionally what you're seeing on the screen, the member match operation is a tool that can be used to identify a member in a payer database by different organizations. The payer endpoint discovery tool is really a broad tool that allows you to understand which endpoints a payer makes available. Finally, there are a number of other concepts within the guide around coverage search parameters, how to actually search for FHIR resources, and different FHIR profiles and that actually constrain those resources. In each slide, I'm also going to provide a link to the guide. The goal here is that we'd be able to distribute these slides and help you understand a little bit more about these guides as a starting point. So that wraps up Health Record Exchange. Again, it's just a foundational guide that contains a lot of different definitions. I'm not going to talk individually about the definitions or what those concepts do beyond what we're seeing here. Generally want you to be aware of these, that they are positioned in this guide rather than in the more specific guide because they are shared concepts. All right. The second guide I want to talk about is Da Vinci member attribution. And I list this second because attribution is an important concept in the market today. You might consider attribution in Da Vinci terms the same as the rosters that you're trading with your payer or providers or other partners today. Those member rosters help you identify which patients are in scope for your services. Member attribution does the same thing. And so you can understand that this is a foundational concept because a definition of a member and who is a member can be important to a lot of different data trading mechanisms. This isn't something that's referenced by every single guide in Da Vinci, but it's something that when you start thinking about how you're going to enable different processes with providers or create your own processes with providers to get the data you need, this attribution mechanism is a really great way to establish that shared identity of a patient, a person, or a member, and allow both organizations to sort of trust that, yes, you are affiliated with this person and you have a shared relationship. The Da Vinci member attribution spec relies on bulk data. So this is a spec that actually is going to allow an organization to pull the entire member roster from a payer in one fell swoop, right? So that's something to keep in mind as you're thinking about rosters and how you trade rosters. You might be able to make available rosters and that you can search for and say, hey, is this patient on your roster? But today, that's not actually part of the attribution concept. So keep that in mind. And if you're interested in doing roster-based work in the future, I really recommend looking at attribution, the member attribution IG as a source of truth for how to get started with that and how to model your data. This is one of those slides that I just included for educational purposes. It outlines the member attribution process for those folks interested. I'm not going to spend too much time on these, just to be able to get through all of the different guides. Right. For payer data exchange is another one of those foundational tools, except payer data exchange is one of those guides that you would consciously implement. And you actually are probably already live with some payer data exchange concepts like the patient access API. Payer data exchange allows for the retrieval of data from payers through different mechanisms and from different parties. And so it defines these different processes to use to get data from a payer for a specific use case, like formulary or payer to payer. The provider access IG is the first part of the payer data exchange, or not the first, but one of the parts. Provider access API allows providers to access data from the payer, and it relies on that member attribution roster. Another important factor in this implementation guide is that members are allowed to opt out of data sharing with their provider. So if you think about this opt-out process and member attribution, if you're looking at provider access in general, well, you need to understand how do you attribute a member to a provider, and you need to understand how do I collect consent or opt out from my members before I even expose this data. So those are two sort of precursors that you need to think about as you're building up your provider access capabilities. From the payer perspective, provider access is crucial because it enables that reciprocity. Real trust in a network means that both parties are trading data with each other and they're getting value out of that. Prior authorization is one way for providers to get value out of a relationship with a payer, but provider access API is another great option. It's also required under CMS 57, so something to keep in mind as you move forward. Payer-to-payer is one of those other requirements out there. It might be that you're already enabling some payer-to-payer data movement today, allowing the quote old payer to push data or provide data to the quote new payer or like the legacy or old payer. This does use the bulk data model again. So what we're seeing here is that we have a lot of bulk data that we're generating in our systems for different purposes. Systems also need to be available just for FHIR queries and for some purposes, such as the provider access API. Payer-to-payer also does enable a single patient model. So that's something to consider here, right? We know that we have to have FHIR APIs for single patients. We need to be able to retrieve data for single patients, but we also need to enable this model where you're able to retrieve data in bulk. Retrieving data in bulk really requires that you're actually identifying the cohort of patients, the roster of patients that are available to that requester. And so outside of just creating those single patient resources and providing those, you now have to think about how you actually model that data across a group and how you create those groups. Another point here is that consent from the patient is required in this case. So I use different terminology here. Members are allowed to opt out of data sharing, and I really should say member instead of patient here, but both models require, well, one model allows the patient to opt out, while the other model requires consent. And so again, now we have two different models that you have to consider in terms of when do you share data and how do you obtain that opt out or that prospective consent to share data. Great. Some educational material on payer data exchange, really highlighting the real complex nature of payer data exchange. If you look at this, there are a lot of different APIs that go into payer data exchange in general, a lot of different systems, including pharmacy, that we haven't even talked about yet. Pharmacy or formulary is another piece of payer data exchange. Payers will be expected to provide a formulary as an API for those that are interested. You can see sort of the structure of that formulary in the screenshot below, where it's really saying that you have to have this formulary presented in FHIR at the level of a drug. And then when you have that drug represented, you also have these different levels where you're either making that drug available on a specific formulary that's based on the patient's data or the patient's plan, or you're actually presenting all of this data in bulk without authenticated access. So to be clear, this guide is really asking you to make your formulary available to anybody that's requesting the data. That's that unauthenticated access piece. And so there's different levels, right? If you have authenticated access, you're asked to provide additional information about your formulary that's specific to the PHI provided, the member ID usually. Whereas unauthenticated access is really just presenting all of that information about what your formulary is for your plan. Yeah, so Allison, you had a good question there. Are there different levels of opt-out for the data exchanges? Generally, we would expect that for our member opt-out, that the member is allowed to either opt out of all data exchange with providers or to indicate that they don't want that data to be exchanged to a specific provider. I think we could dig into that further if there are specific concerns or questions. I don't have the context of the IG to say specifically if the IG states how this must be done. That's something that we could certainly follow up on here. But if you think about how patients act and how patients want their care to, flow downstream, it's quite possible that you really want to allow a patient to opt out of sharing data with a specific provider organization or either a specific provider like an NPI in some circumstances. It'll really depend on what you're able to do and how you define that data sharing in the first place. How you make data available to those providers is really going to drive that process. The plan network or plan net is not from Terminator. It is an implementation guide for the provider directory concept. The provider directory is how a payer exposes the networks that it contracts for or it creates via contracts. So you can see here, we've got a kind of complex relationship of different FHIR resources that make up this network. And what it's doing is really defining the providers, the organizations, the actual physical locations that are contracted with a given insurance plan. And again, this is a really foundational concept for any tool that leverages that network to understand, to derive different information. And you all are more the experts on how that works. In the background, what I understand this to be, though, is that really sort of making or exposing your plan network and enabling organizations to really identify which providers are in network or out, for example. Richard asks a great question. If the patient opts out of provider data sharing, are they removed from the attribution list in member attribution? Uh, I believe the answer in the IG is, I believe the answer is in the IG there. I believe that the answer, well, I shouldn't take a guess there. I think we can follow up on that. Chris, thank you for your answer as well in terms of how you choose to define consent.
I mean, I don't want to be messing with the attribution list over and over again.
Yeah. All right, here's just another look at that provider access API and how it can be kind of generated or defined. Again, the provider access API you can see here is it's really driven by member attribution, right? And member attribution is then driven really upstream by other processes that you're enabling. So if you think about what claims did I receive from this provider for which patients, or what CRD CDS hooks did I receive? Those are attribution. Those are saying that this provider has a relationship with this patient. And so what you need to think about when you're building attribution for a given provider organization is what information do I have flowing in that actually tells me this? How do I build that attribution list outside of just my own guesses or my own knowledge? Okay. Da Vinci burden reduction is the electronic prior authorization. Hopefully folks are pretty familiar with this one. It's a big lift required in 2027, and we've got a lot of ongoing pilot work and different activity around this. The burden reduction IGs there are 3 different IGs. So it's not really a single burden reduction implementation guide. It is 3. You have CRD, DTR, and PAS. And we are actually doing specific education sessions on each one of these IGs to help break them down because they are individually pretty complex. Michelle mentioned at the beginning of the the meeting that that we did a CRD education discussion already, and that's available for folks that are interested. The purpose of burden reduction IG is to ensure that the patient needs a prior authorization for a given procedure, or to actually move along the process and say that they don't. And then finally to actually create and submit and respond to that prior authorization. So this truly is making that process more electronic and kind of more automated in a lot of ways. There are a number of different considerations with burden reduction. We do recommend starting off with CRD as the first guide if you haven't gotten started there. And then as another aside, there's this whole concept in prior authorization around the X12278 because of the HIPAA law stating that prior authorization should be submitted via an X12278. There is enforcement discretion available so that this can all be done via FHIR. But there's some complexity here around how you receive and respond to 278s that we should, that we'll be digging into in a future education session. Yeah, good question, Janice. We only had CPT codes listed in the on this slide here as a way to describe a procedure. I actually would like to pose that to the rest of the crowd here. Are payers that are implementing CRD implementing procedure lookup or identification only via CPT, or are you also thinking about SNOMED? Okay. If folks have ideas or thoughts, please throw those in the comments. CPT is really the starting point, I would say, for a lot of this. It's more typical nomenclature for the procedure that's actually performed versus SNOMED. But I think we would have to really dig into that further to discuss where it adds value or doesn't. Go ahead, Allison.
I was just say from the Cognizant side, we're supporting both CPT and SNOMED, so we can do a conversion from SNOMED to CPT or ICD or HCPCS, whatever. But we'll also support CRD requests coming in with CPT codes.
Thanks. Yeah, so this is that little bit about CMS enforcement discretion, allowing for that FHIR bundle to actually be the full end-to-end process for prior authorization support or submission. I think it's really important with prior authorization just to continue to highlight that CRD can actually provide prior authorization approval, and what we're seeing is that it's in a very high number of cases, over 50%, with the pilots that are ongoing. So really getting started with CRD and piloting that even in a production state with clients can actually add a lot of value. It's important to understand how that works and how it might work with your organization, of course, but CRD is a great process to get started with and to build your understanding of the downstream DTR and PAS processes. This is just more education information for folks that are interested. The next guide is CDEX. Da Vinci CDEX, or Clinical Data Exchange, is the mechanism to exchange data. Really, it's often from a payer's perspective, the request being a payer-initiated request to a provider, but not always. And this is just a way to push data around the system without another process ongoing, like burden reduction. So to dig into that a little bit, CDEX defines ways just to make typical FHIR queries over a network. So how do you make a synchronous FHIR query from a payer to a provider? It defines that task-based approach in further detail, leveraging HREX as a starting point, and allows for that task-based approach to enable data retrieval by the payer asynchronously. So if provider organizations need a person to work certain data requests and sort of sign off on it or get the right data, that task-based approach is the right method to do that. CDEX also defines attachments, which can be provided alongside prior authorization submissions. So that would be a solicited by a payer or unsolicited push from a provider. Finally, this concept of signatures is also addressed in CDEX, although I haven't seen a production implementation of this in the real world yet. Signatures on data is a key issue that I see ongoing that we don't really have great visibility into how it will work in the FHIR world, because in part ONC hasn't required anything by the EHR or the payer to support via FHIR, right? There's no FHIR requirement for signatures, for example. So that's something to keep an eye on if you know that your data needs to be signed by the provider, asserting that the provider is the original source. There are alternative methods that you can pursue for electronic data exchange. Feel free to reach out or throw a note in the chat. Just another comment. Within Trebuchet, we've had a lot of success with CDEX. One of the things about this is that payers need data, and they're often asking for data that has to be manually fulfilled. So if a payer needs data regularly from a provider, it's often in the best interest of both parties to automate that process of getting data from the provider via FHIR. We have a number of different production CDEX implementations that work, that providers sign off on, that payers can use, and that builds trust between those two parties. So if you're a payer looking to dip your toe into FHIR, CDEX is a great use case to do so because it is relatively easy to stand up. It's sort of a mature model that you can approach through Project Trebuchet and get a lot of support with. Definitely recommend taking a look at this to see if there's a way that you can move that forward. Ellen, good question about CDEX. Is it the appropriate method to send gaps in care, care plans, advanced directives to a provider? Sending data to a recipient is not an easy topic in FHIR. That push of data is not typical in FHIR. There is a risk adjustment implementation guide that we're going to talk about in a little bit that might better address your needs. If the provider is willing to query for that data and ask for it, then the provider access API is the right method for that. Muhammad asked about CDEX for exchanging bulk data between payer and provider on a fixed schedule for HEDIS. The way to exchange bulk data between a payer and provider is actually just the bulk data standard to a degree. There are the provider access API is a great way for providers to be able to obtain data from payers. If the payer is looking for bulk data from the provider, there's some nuance to this. The DEQM specification that Samira and Providence did is a way to enable that. I think there are some workarounds that you have to employ to use that IG, but there are different specifications out there that you could look into. Really, the bulk data implementation guide is a good starting point, and that's what we, the eHealth Exchange, worked on with Multicare and Cambia for a NCQA project, a bulk data movement project. So looking at bulk data generally as a standard, it's not a Da Vinci standard, but it's one that you can leverage and use in production today, is a good starting point for that. This is just a quick diagram on some of those CDEX flows. Really what you're seeing is the payer initiates the flow for the direct query and the task-based query. Okay. All right, so data exchange for quality measures, or DEQM, is used to support those value-based care arrangements between providers and payers. What I wanted to highlight is what this IG does in a little bit more detail. So the IG itself calculates individual reporting measures or enables calculation of individual reporting or summary reporting measures, as well as this concept of a subject list. So that's the data that's being exchanged. It's actually measure reports, outcomes data at the individual and summary level, as well as this clinical, quote, data of interest, which is I think the way I would define it is the FHIR resources that were used to calculate those quality measures. So this as a tool is intended to allow for organizations to share HEDIS measures or other measures and the underlying data. It's a great way to think about quality measure transmission in the future, something to work towards. What you might want to know is, like, how do I define my population, or how do I understand, which patients are in scope? So going back to member attribution as a mechanism to do that is really a good starting point. A lot of the IGs create these, I'm blanking on the term here, but these $ operations. These are FHIR operations on a specific resource type. And what it allows you to do is to implement certain logic that occurs when that operation is executed, right? So it's not just a HTTP query for data, there's a little bit more to it. So you can use this $submit data to send quality measure data to a consumer. So a provider could use that to actually transmit or push quality measure data to a payer. And the $collect data is sort of the opposite, where the payer can go get data from the source, the provider. There's also the ability to request care gaps for a patient, group, organization. So at whatever level you're interested in, to be able to obtain all those care gaps, and you can probably do that from either party. Just a little bit more information about DEQM here. And oops, moving on to risk adjustment. So the risk adjustment IG really focuses on care gaps specifically. It is the exchange and generation of care gap report data. So it actually provides more of a definition around what a care gap is, and how to transmit or receive that risk adjustment coding gap report. What it also allows you to do is actually change data in most likely the payer system to push gap information, so you can close that gap or maybe invalidate a certain gap as needed. So it allows both organizations to sort of maintain and manage those care gaps. There's also this concept a lot in FHIR where we're seeing sort of packages of predefined FHIR resources. These packages, the digital condition categories, for example, are really going to say, here's exactly what information is minimum necessary for a given concept. So that allows you to kind of predefine what information is required rather than having to build a query from scratch for a given care gap or quality measure. There's more to it than that. Apologies for staying high level, but really with some of these guides, what their intent is to make life easier to perform certain processes, right? And in this idea, this package is really about the ability to obtain the right data without having to specify that. Yep. So here's just a quick overview of the Medicare Advantage workflow for risk adjustment and how that might function. Okay, that wraps up the high-level IGs that I wanted to talk about today. There are a few other implementation guides that are owned by Vinci. I wanted to just quickly mention, I didn't give an overview of each of these. So postable remittance, value-based performance reporting, patient cost transparency, and notifications are all additional IGs. I think most of those make sense just from the name, the title. The notifications IG is really about a provider notifying a payer of an admission or some other event with a patient, a lot like what you might be doing today with your admission notifications. Okay, let's talk a little bit about regulatory topics and how this all kind of works together. So the CMS 57F rule is really the impetus behind a lot of the upcoming requirements in 2026 and 7. And it's always important to kind of highlight what that actually requires and what it says. CMS 57 doesn't require Vinci implementation guides. You can see on the screen here, they're all recommended. There are also some Karen guides, Blue Button, and some other non-Da Vinci guides that are recommended as part of this process. The reason these are recommended is because we need organizations like everyone on this call to work with them, to adopt them, to test them, and make them better. They will be required when they are of sufficient maturity for us to say concretely, these work really well, and you do not need to make any changes to them in order to get them fully functioning in production. So we do need input, and that's why we need testing, and that's really why we're here. I think if you look at the requirements in the 57F rule, you can see that FHIR R4 is required, that you have to support, certain standards like Smart on FHIR. And when you think about it, like, okay, how do I stand up a provider directory API using FHIR? The easy answer is to start with the Da Vinci IGs. I think the way you can think about this required versus recommended is that the Da Vinci IG is a great starting point, and you should try and comply with it as closely as possible. But if there's something that doesn't work in that IG for you, and you really can't comply with that, that's why we were saying recommended versus required. So we want that feedback. DaVinci needs to incorporate that feedback back into the guide so we can make it better. But we can't approach, if you were to go out there and try and define your own provider access API via FHIR, what you're going to end up with is something that's similar to the provider access API that DaVinci created, but nobody's going to be able to use it, right? So like in order for us all to be interoperable, we have to rely on single standards. That's what standards are for, and that's why these are free and open. And so like working together to mature these standards is, my pedestal, and I'll continue talking about it. We need to find ways to do that. And I understand that sometimes these standards don't work for you, or there's something that doesn't work about them that you want to change. That's the feedback we need. It's super important that you can expose that feedback to us through your testing and that you're communicating back. I do want to call out there are some not listed guides in CMS 57. There are things about that DaVinci does that are not required. A lot of these things are going to add value to you, though, or to the provider organization. Like CDEX and DEQM are actually getting adoption out in the real world because people are doing it today and they're struggling using these non-standard methods. I could let Michael Westover or Samira talk about how Providence spent, hours of or hundreds of hours of time with different unique flat files per payer as they're trading quality measure data. What if we lived in a world where we didn't have to do that and everybody generated data in the same format? It's amazing, right? Like we can all save time and energy, and all we have to do is move towards these guides. All right, I'll step off my soapbox. The foundational concepts that underlie all of these guides are listed here. I think it's really important that you understand these concepts, and you don't have to know every detail about them. I don't know everything about FHIR R4, but one of the things that I wanted to define here is what is US CDI versus US core, right? Because a lot of people talk about these terms, and it's kind of complex. So FHIR R4 is the data standard. It's the transport standard that's used to send data back and forth between organizations. US CDI is the thing that's understood by the practitioner, by the user. And that's really important because with US CDI, we can define something in the EHR that the user interacts with, that the provider does as a FHIR R4 resource. And the US core is what helps with that translation. So it's, this is just one topic, right? It's really important to understand all of these different terms and what they mean and what value they can add for your organization, or why you want to avoid them if you don't want to adopt them. Another one is Smart on FHIR applications. A lot of organizations are really interested in Smart on FHIR applications. Smart on FHIR is not a great tool for payers right now because it's not helping payers comply with most of these IGs or these standards. Most of what payers need to do is a back-end service, the ability to make data available to an authenticated or unauthenticated user. And so Smart on FHIR applications aren't really going to assist with that. They'll help with testing how you make data available. But all Smart on FHIR app is doing is making a UI or a client available to a user so that they can interact with your backend. One of the things we don't want to see in the industry is every payer creating their own Smart on FHIR prior auth application. No provider wants that. They don't want an application per payer. That just is a little bit of a difference between the current portal system they have. So it's not the future vision that we're all looking for. Right. Authentication is really crucial, of course. I think everyone here is focused on security to some degree. The authentication methods that are presented in the guides are relatively standardized. That Smart App Launch Authorization is a mechanism to allow a user access to your backend APIs through the Smart standard. Mutual TLS is one concept that's going to be really important in the future when it comes to national networks. When you're working or if you're thinking about TEFCA as a way to move beyond point-to-point connectivity, mutual TLS is the way that you're going to understand who's actually communicating with you for a given request. Mutual TLS is an important standard from the security perspective for those national networks for TEFCA. And I think a lot of folks on the phone will really understand that point-to-point connectivity is just not going to scale well for large organizations. If you need to connect to 1,000 payers or 1,000 providers, you can't go to each one individually and set that connectivity up. It will take too much time and cost too much money. So it is very much preferred that we move in the direction of the national networks like TEFCA. That's one of the biggest reasons why TEFCA is in existence and why we're pushing on it so much to be useful for providers and payers alike. The other side of TEFCA is that UDAP, or I'm sorry, Security and for Scalable Registration, Authentication, and Authorization, or FAST Security IG. This is a way to automate the process of getting access to anyone's FHIR data. Under a national network or a trust network, you can use this implementation guide to automatically get access to a FHIR server for a given purpose of use. This could be super powerful, and it is the next generation beyond that point-to-point connectivity that everyone is really struggling with today. Outside of the authentication mechanisms that are used in these guides, I think it's important to understand that there are open endpoints out there. That these are things that you're exposing data to the world without any authentication. It's actually required by the guide that you do that, sometimes for very good reason. So the formulary data, plan network data, and your endpoint discovery information should all be unauthenticated. And really that's so that organizations can access the data without necessarily being authenticated with you. For example, I can't really know how to query your CRD endpoint without the payer endpoint discovery URL. And if I have to authenticate with that payer endpoint discovery URL, I might not be able to access that information as a starting point because I don't know who to authenticate with. It's a little more complicated than that, but generally you do have to consider what endpoints are going to be open and available to the public versus which ones are behind authentication, and what authentication you're going to use with your trading partners and for each use case. Different use cases can require different authentication. Another key sticking point with organizations that are really moving forward in production is to think about sensitive and confidential data. There are different cases, and I've listed 3, technically 4 on the screen, where it's very important that that a payer is not obtaining data from a provider without specific authorization, or in the case of number 3, if the patient actually requests that the data is not shared. I think one thing I could ask all of you to do is to be specific when you're talking about sensitive or confidential data, because there are different rules in place for this information. And without understanding what specific information we're talking about, we end up saying really broad generalizations. Oh, I can't share that information with you. I can't make my FHIR APIs available to you because that information's in there. That's not necessarily the case. We can solve these problems, but we actually have to get down to the level of detail of what piece of information can I expose to you or should I not? How do I do this work? How do I make sure that a self-pay encounter isn't exposed, or that I know when a patient requested to not expose that data? Providers need to do a lot of work in that space to really make sure that they're securing the data in the right ways. They're the ones that are generally responsible for this if the data is in their system. But payers need to really understand these terms at this more specific level, and they need to understand how they want to approach this data or the data retrieval around these terms. This is going to impact how you make FHIR API queries. It's going to impact how you access data and what scopes you request when you access data. State laws are also very important. I can't get into all 50 state laws. I'm not even a lawyer, so make sure that the states you're operating in, that you understand if there are specific laws on the books that govern additional data and sensitive data. Okay, I talked about this a bit already. Patient consent's a big piece of this. How do you collect patient consent or patient opt-out in the right ways? When's the right time to do so? I think the payer organizations that are out there doing this, I know Cambia's looking to get some patients opting in or out of provider access pretty soon. They're going to be able to share their experiences, and they'll be on the Trebuchet calls doing that So if you're an organization that's trying to figure this out and you have questions, that's what this group is for. Please come, bring your questions like those, and let the experts help you, or just let those folks who have done this before give you their advice. It's really the operational processes around how you do this. It's not the technical lift of doing it that is critical. For example, do you introduce patient consent at member sign-up processes? The other one is how you store consent, right? I think everyone needs to align around how we store and transmit consent, and there's a lot of work to be done in that space. Okay. I probably talked your ear off already. So a few just next steps or just some different thoughts around how you might get started here. Every organization is different in what technology you have available today, but here's an idea around some example phasing, how you might go about implementing these different implementation guides. I've already talked about the foundational need for these guides, and really phase 0's current state today, because it's likely that you already have some capabilities set up for these concepts like provider directory or patient access. Phase 1 really is the bulk of the work. This is everything that we're talking about before 2027, in some cases even earlier. Member attribution being a really key one. HREX endpoint discovery is a really core to burden reduction. Making your plan network available and related security and authentication, standing all that up, it's a huge amount of work. So that's really where you need to focus your time and energy. Phase 2, looking at provider access, payer-to-payer access, is going to really come from everything that you've already set up here. All this is really the FHIR data that you might already have available in your system or that you're actually collecting through these other processes. Yep. So basically the same thing I said. Apologies, I forgot to click through those. Okay. A few implementer resources are here. For folks that are not familiar, we do have the Confluence pages that Michelle and Mike have linked to in the chat. The Zulip channel is a really great place to bring questions to the IG leads. So if you have questions, if you're critical of an IG, if you think that it needs to change, like, these folks are there to listen, they're there to help you, as well as to provide their advice around how you might make it work for you. So please leverage the Zulip channels. This is how we work together as a team to get this stuff improved. The FHIR Foundry has a lot of reference implementations and different code that can help you get started from the technical level. And there's Touchstone as a tool that helps you with testing and other support processes. With that, you're already familiar with the Trebuchet meetings because you're here, but we definitely welcome you at all of our public meetings. Please join, please bring other folks. Again, we'll be posting this presentation along with the PowerPoint. So if you found this helpful, send it off to other folks. Let's get the word out there, help everybody understand what they're dealing with. If you didn't find this helpful, we'd still love feedback and to understand better what you need and how we can approach that discussion to provide education. It is one of my goals over the next 6 months to continue to provide education on these topics and to build our knowledge base as a community so that we can all kind of thrive in this space and get the job done. So please leverage me, leverage the Da Vinci team here to help you all get started or to get a pilot going or whatever else you need to really move forward with the IGs.